This week on the BackTable podcast.
But if you told an interventional radiologist you're going to do a procedure that you've never done, but you've got the know-how, you can do it, you have the technical skills to get it done, you just haven't done it, most people would say game on, that's fine. And they have like the baseline skills that you need to do the procedure, you just don't have all the know-how, which has happened to me. Like I remember like for the same procedure I was talking about, and for all the prep that I did, when it came time to like inserting this device, I had the package insert open. So this is a little piece of paper that tells you how to deploy the device. The patient's on their belly, and I have that piece of paper open on their back, and I'm reading that as we're putting in the device, making sure that we're doing it correctly. I had it in my head, but I was like, well, the package insert's right here. Let's just keep this open.
Yeah,
Can't
let's
hurt.
just see.
Yeah, it can't hurt.
Baxter.
You saw that?
Is that a new one?
Yeah, I just put that in there.
Nice.
I got a million of these. I got Baxter, Beck by popular demand, Baby got Beck,
Baby got Beck.
Beck in business, Beck to the future.
Back to the Future.
There's all kinds of good ones.
What's your favorite?
Probably Baby got Beck.
Where did these come from? Who says these?
Oh, I don't know. Like you just like if you have a last name like Beck, that I mean, really anything that has back in it, you can just like sub in Beck and then they just start rolling and then friends like pile on. My brother, who's a plaintiff's attorney, he doesn't do any advertising, but like the jokes are always like with him, like getting a wreck, call Beck. He'll be at your beck and call. Like there's all kinds of good stuff. Yeah, it lends itself well to stuff like that.
I can't say I had the luxury of that with a last name like Parikh.
Nah, few and far.
Parikh the Freak. That's all.
Oh, that's not bad. I like that.
So we meet again, Baxter. And what I want to know about is how many years out are you?
11 years. 11 years.
Do you think about like being out from training as like a hallmark date, or is like, does it all just like continue? I started being a doctor and I kept being a doctor.
No, I kind of thought of it. You know, I didn't give it a whole lot of thought, but then it was like I woke up one day and all of a sudden I was a mid-career physician, and instead of me looking to partners or, you know, having to phone a friend, I felt like I was more receiving phone calls and like sometimes younger partners asking me for advice. I don't know when it happened, but it was like all of a sudden I went from being the new guy in my group, building up a practice, and then all of a sudden I was like handing over a practice and feeding the younger guys and then, you know, fielding questions. Like the reason I remember that because I had like major imposter syndrome. Like I thought these guys were super talented, well-trained. And I was like, why am I telling you what to do? I mean, you guys probably know better than me. But, you know, at the same time, I just tried to give the advice that I could. But yeah, I think it happened when I was like 7 or 8 years out. And then I don't know when it happens, but I assume one day I'm going to wake up and you're just like the old guy and all the stuff you're talking about's totally antiquated and people like do not want your advice.
Right. As far as my kids are concerned, I'm already the old guy.
Yeah. So when do your kids realize that? Like when they turn 10?
Yeah, 10 is fair, I think. It all depends, but yeah, 10 is fair. Then it keeps going. Just starts then and it keeps going.
Right now my kid is 5 and it's a fantastic age because she really believes in her heart of hearts that I know everything. Partly because I did tell her I know everything. and like we keep the ruse going. Like we'll just be walking by and she'll be like, who's that? What's their name? I'm like, Jimmy. Where's Jimmy live? Up the street. 3 doors down, blue house, red door.
If only it were so with interventional radiology. Or maybe you do know everything. I don't know.
Nah.
As the host with the most, maybe you do know everything.
No, not even close. Not even close.
Do you feel like there was a change from what you were trying to learn when you were a resident to fellow to, 3 years out to 7 years out to now 11? Like, what you're trying to learn, how's that changed?
It has changed. When I first came out, it almost like I was always searching for the right answer, the perfect way to do things. What are the people like on the like very cutting edge, high-end institutions doing and how are they treating patients? And I don't want to say that I gave up on that, but that became less of a concern. And maybe more of a concern was like, how do I take care of my patients in the best way possible? Like with the resources that I have available to me, with using like the tools that I have, because like the tools that you have and the resources that you have available like directly informs like the work that you do and like how you get things done. And so that became like more of my focus is how could I maximize like the things at my disposal on the ready without always like having to hit up like the C-suite or the leadership for like a new thing. And so I stopped like thinking, hey, there's like the right way. And I started thinking more about it like, what's the right way for me?
How do you craft that, I guess? Like, how do you get to the right way for you? Like, what information goes into that? I mean, is it more about repetitions? Is it about, learning from other, like, how does that work?
Like, I don't try and like put my head in the sand and not understand what people are doing at like, the tertiary, quaternary referral centers. But at the same time, sourcing a lot of different information from as many places as possible. Like, I'm more likely to call maybe less somebody at like Georgetown, one of my hometown institutions, and more likely to call someone who's at like a community practice, more like myself. On top of that, source it like the typical ways, like not uncommon for me to source like archived BackTable episodes, even ones that I've hosted just as a refresher. There's some good online tools. Like I think we've talked before on this exact subject. And, I still go to, like a search or a Google, but, Google now is kind of like synonymous for me with like, just going straight to Gemini or some kind of chat GPT. So even though I'm saying search, like it's really like usually an AI resource.
Well, I mean, it makes sense that you would look up those BackTable episodes hosted by you since you know everything, but makes sense.
Sometimes I feel a little bit sad. Like when I'll go back to an episode, I'm like, man, this is going to talk exactly what I want to know about. I'm like, oh my God, I hosted it. And I have very little recollection of that event.
Yeah. Well, you were paying attention,
Sure.
But I guess let me ask about that. I mean, I remember the first time that I talked to somebody is 2016. We were talking about starting BackTable, and I'm asking a bunch of docs like, hey, how do you prepare for a procedure that you haven't, not that you haven't done before, but like you don't do regularly, not one of your bread and butters. How do you prepare? I'm like, well, I mean, I might read a textbook. Now this is 2016 and that was already fading, a journal article here or there, but I'm going to ask my friends, like my co-residents, sometimes gals in my practice, then I'm going to go on Google. And like that last part actually just like caught me by surprise, not being a physician. Like, I mean, I use Google for that, but then like, wow, okay, you're a doctor and that's where you're going for that info because maybe it doesn't live anywhere else. But what I'm hearing you say is like, that's still a big part of that prep is going to Google. I mean, like, and so I guess my question is like, what are the scenarios where you do go prep like that and the internet gets involved?
For me, it's always going to be involved. I mean, it's just such like, a major part of like the way I work and research. I will still like reach out, like phone a friend, but there's just something that's like nothing like more convenient than just being able to like pop open a browser and then get to searching.
What would you search for? Like, what's an example of what would happen and then like that you have to search for something and then what would you search for?
Yeah. So like if I had a new procedure that I was taking on, whether it was something like I was maybe needed a refresher on or something that was just completely new to me, like one that kind of comes to mind, even though it was a while back, putting in double J ureteral stents, which was just not something that I trained on, but conceptually, like I knew what to do, kind of how to do it, but it was just not something that the interventional radiologist covered. Like that was covered by the urology service. And the practice that I was at, like every now and then you had to put one of these in.
So yeah, actually, let me interrupt you and ask. So just again, as the layperson, like help me understand this. You're an interventional radiologist. You trained, I don't remember where you trained, but as a reputable establishment,
Quasi.
And then there's this, right, Fritz trained there, so it couldn't have been that good. Right. It was you, Baratza, and Fritz, right?
We were all Vandy together. Right.
Okay, Vandy. Yeah, so quasi.
Yeah, exactly.
I guess you didn't train on every procedure known to IRs, or this was new at the time, or just like...
I wouldn't even say it was new at the time. It was just something that we really didn't do. I can't say exactly why we didn't, but I would say like it fell into one of these categories of procedures that has overlap with another specialty. And so sometimes when you're at these high-end referral centers, like that procedure will belong to a specialty that's not interventional. But then you may go to another location and they're like, no, we do these all the time. This is like standard operating procedure. And that's kind of the situation that I found myself in.
Okay. So, there are IRs in other places that do it, but you hadn't been trained on it. But now the practice is like, okay, Chris, you got to do this, basically. Or somebody's got to do it and you're up.
Yeah. No, that was very much like I came to work that day and it was on my board. And I'm like, double J ureteral stent. I was like, I'm pretty sure this is a mistake. And then one of my partners was like, no, it's not a mistake. Like you can do that. And so he kind of talked me through it. But then, I went to Google, but even when I'm in Google, I'm not going to rely on like the source, like I'm sourcing it smartly in that like, I'm looking for like specific sources for Google to kind of point me in the direction. Like there's a fantastic journal that I love. It's called Techniques in Vascular and Interventional Radiology. And it's very much like A to B, soup to nuts, how to do a procedure from a very technical standpoint. And that's what I was looking for. Depending on the complexity of the case and like the patient population, I kind of explore it then from different angles. Like right then I needed to know how to do it. And so like my focus was on the technique. But then like as I was like, well, I'm going to do more of these. I want to like hone the craft. I want to know about patient selection. I want to know about complications. I want to know about all those other things about how to choose the right patient and get it done smartly and efficiently. I'm still using Google or some kind of search, but I'm still like, I like to say like discerning about the sources that it refers me to. And now actually there's a new thing that's out there that's called Open Evidence, which is an AI-based tool that will basically only source, and I could be messing this up, so I could be misquoting it, but by and large, it sources peer-reviewed resources. And so when you're getting it, you're getting peer-reviewed journal articles that it kind of puts you in the direction of. It's pretty high yield.
Yeah, I think that's what they tout anyway.
Yeah.
That's how that works.
Yeah.
So, okay, so you go to Google and you search for this procedure. Or did you search, I mean, you were looking for the how-to on this procedure and, and then you finally found this journal you mentioned, like the technical journal of IR, essentially. And then like that gets you what you need. How often is this happening? Like, you doing this all the time?
No,
or like,
it's relatively infrequent these days, especially like where I'm in my career. I mean, it depends on how adventurous of an interventional radiologist you are. I mean, like there are plenty of times like when people ask me to do a case, to me, it falls into this gray zone where I feel like I have the technical skills to do it, but maybe I just haven't found myself to do it. If I'm going to research a case like that, like something like this that I decided to take on, that's maybe a little bit more, I guess you would call it less urgent, less acute, then I have time, in which case I'm going to try and watch some lectures on it. I think SIR does a good job of catalog. Actually, they don't do a great job, but they have something called the Digital Video Library of Society of Interventional Radiology. It's basically all the lectures that got given at SIR. And if you comb through that kind of thing, like you can find some real fantastic lectures on people just like telling you exactly how to do the cases you want to do. And oftentimes there's a whole session on it. So it'll be like 3 lectures on how to do something like thyroid ablations, which I can do thyroid biopsies, which is a different procedure, but a thyroid ablation is kind of just like the next iteration, like different needle, same anatomy, different risk profile, but from a technical standpoint, it's not a whole lot different. Those are the cases that I feel like come up more often. It's like they're extensions of kind of what we're doing.
I mean, is all this changing a lot? Like, again, dumb question. Why does there need to be a lecture on this every year at SIR or something like that?
For me, it actually is changing. Like the things that I trained on, the scope has just like gotten so much broader. Like the things that people are doing are so much more adventurous. And like, it's like every year people are continually pushing the edge of what exactly an interventional radiologist is and what we can do. I know that we've had another conversation, like when you think about an interventional radiologist, the way that I think about it is like the scope that you're responsible for, it's like anything you can do that's relatively minimally invasive, and that's kind of got a question mark, but minimally invasive and image guided. So literally you can be working in someone's toe and then your next case, you could be in somebody's brain, and everything in between is fair game. And when that's the case, it's just, there's a whole lot that you can do. And then you start borrowing from other specialties, technology changes, the things that we have, the tools are improving and really kind of changing to meet patients' needs. There's just ends up being a whole lot of procedures that you can really get into. And IR by and large is becoming increasingly subspecialized. And so it's like, okay, so I'm let's just say, all-purpose, jack of all trades, interventional radiologist. There's some people who specialize just in doing the prostate. And so they become like whizzes at doing things in the prostate. And like your brother, who's like he's doing cases that like, I'm not saying I couldn't do, but he's working on a different level when it comes to like his field than what I could expect to do, because this is what he's doing all day, every day. And so those types of docs are pushing the boundaries of what interventional radiologists can do and are expected to do. And so, yeah, I'm trying to keep up all the time. I mean, it's tough.
Yeah. Well, so do you have, separate from prepping for a procedure, do you have like a regular cadence of information that you're consuming to keep up?
For the regular keeping up, I think because I'm in the unique position of being the medical director from the VIR show, I have to consume so much more interventional radiology information, more than I truly want. And so I have all the IR.
What do you mean? Like in terms of the episodes?
Oh yeah, all the episodes.
You listen to 2 episodes a week at least, right?
Yep, 8 per month, 96 a year, no breaks. And then now with the app, additional content on that. So I have all the interventional radiology I need. But before I was the medical director, and it's not like such a long time ago, I was using BackTable a whole lot.
Way back then.
Yeah, right, way back then. I was using BackTable all the time. Like I thought that was a great way to have your fingers on the pulse of like what people were doing, innovative techniques. Yeah, and I still think that's like a fantastic resource. And I know I'm biased, but I mean, I think it's a great way to like just, even if like you maybe want to double click on a couple of things, like you could do a lot worse than like listening to BackTable and understanding like kind of where the field is on things.
At that time, did you listen to every episode, or did you have like a regular time when you would listen?
Well, I'm embarrassed to say like the amount of like, I wouldn't put on air like how much podcasts I actually listened to, but like I was listening to a good bit. Like BackTable to me still like falls under edutainment. Yeah, I'm just as inclined to listen to an episode because I think it's going to be clinically interesting versus entertaining. Like some of the things that like Barraza does, like I find like truly funny. With all that being said, I was still probably listening to episodes that I thought were going to be interesting and like informative of the practice that I had at the moment. If something came up and it was like men's health, I'm like, oh yeah, I definitely want to listen to that. Or women's health, yeah, I definitely want to listen to that. But liver-directed therapies or oncology treatments, we definitely did some, but like I didn't feel like the need to like push the limits on that. And so I may or may not listen, plus or minus on who the guest was.
I don't know, sometimes I hear Aaron talk about it. I wonder if the pace of evolution of the field is this like this boogeyman that's chasing you as a physician. You're like, I gotta get ahead of this. Or you're like, I'm good. I'll learn what I need to learn, you know.
Well, so that's also what I've gotten more comfortable with is mid-career. Is like originally early career, I always thought like the right answer, the best way to do something was in a journal article or an episode or a lecture. And I just needed to watch that. And then I would have the answer. And then my practice would be transformed because of it. I'm a little more comfortable now with, I can get the job done with the tools that I have. Like I wouldn't pretend like, you know, if you took me and your brother or someone who specializes in prostates and like, you know, put the timer to us on like doing a prostate artery embolization, he would beat me, you know, maybe 9 times out of 10, maybe 99 times out of 100, maybe 100 out of 100. But at the same time, like, I don't think like in the end, like we're providing like radically different services to our patients. Like, you know, one time one of my old attendings explained it like everyone in interventional radiology gets to the same end. It's just, are you a sports car or are you a punch bug? And sometimes like, you know, slow and steady gets the job done.
If what we've accomplished today is calling my younger brother a sports car, I would like to
edit that.
I would like to edit this out. Yes.
I listened to an episode that Nine did recently with the urology show. I mean, oh, it was fantastic. I thought he handled himself so well. I thought so. I mean,
it was set up as like as a debate because I know there was, well, and that was the design, but I know there was some skepticism on Ruchi's part about this treatment and, you know, probably for a lot of urologists is my guess.
Yeah, I think she represented like the majority of what urologists would be thinking when they listen to the episode. But I just thought Nine was a consummate pro and like he just handled it like he was not unprepared is what I'll say. Yeah.
No, he speaks very well and he, you know, he's good at that's his jam as well. That's cool. I have to listen to that actually.
It was really good. And especially like, I mean, I don't know, like there were some like provocative things that he was saying. I mean, you know, quote unquote provocative in the interventional radiology
such
realm.
As
just like, you know, advocating for this procedure, like, you know, what they're doing at Moffitt is certainly like probably outside the box of what people are doing. But what he's telling you, he's like, what we're doing is probably, I'm putting words into his mouth, but he's like, this is the way of the future. And he's like, you know, just get on board, listen to Nine. And I kind of felt like he was right.
What are you going to do with that as an IR?
Well, it's not,
if anything.
Right. It's not a big part of my practice, but certainly like within like our radiation oncology colleagues, I think we're open to have a conversation about being like an adjunct and like helping them in their practice and, you know, treating patients with prostate cancer also may have like bladder outlet or lower urinary tract symptoms. Yeah. What it kind of gives me the knowledge, it gives me the tools to have that conversation with a rad onc.
Okay. So now you're equipped kind of to go kind of get into it to an extent. Like what conversation would you then have with the rad onc?
Well, so on his episode, there was a radiation oncologist, a urologist, and Nine, who's IR. And so I would just say, you know, hey, are these like pain points for you? Like, are your patients like who you're treating with, you know, radiation to the prostate? Are they developing lower urinary tract symptoms that are difficult to control? And this is a procedure we could offer pre-procedure or pre-radiation. And if we do that, it's also going to give you these advantages as far as like shrinking your radiation field and controlling your symptoms better later on. And I mean, I think like a lot of rad oncs would be open to that. I mean, it's no skin off their teeth. You're not taking business away from them. To me, it's like just a nice adjunct to like taking better care of patients. And then like the converse of that is like there's a medication you can give, it's like high-dose steroids, and it's like, has that ever actually worked for you? Like, I mean, we do that. It's part of the algorithm, but like, let's think about this. And so food for thought for them.
IR is a bit unique in a way in that BackTable has become so prevalent. And I mean, I hear people telling me all the time, like, oh my gosh, BackTable, it's great. And, the reach and the content and all that stuff, which is always nice to hear. I'm curious, what do you think? What were people doing before?
Yeah, right. I can speak to what I was doing before because, before we started it, you're just reading articles, listening to lectures if you can get your hands on them. There was still like the Society of Interventional Radiology, which was supplying some content. VU Medi was coming onto the scene. They were doing like, capturing webinars and just kind of putting that out there. But honestly, I mean, I think that's one of the reasons like BackTable kind of rode the wave that it did is there was this vacuum that just wasn't keeping up with like the paces of like how people were learning. And then we just kind of slipped into that. And that's what made it so successful partly is that like there was clearly this educational vacuum and this need for content in a different way that people were learning different ways. And we just happened to be at the right place to be able to supply that.
I'm guessing you have some friends and peers who are in other specialties, even in some surgical and some not surgical subspecialties. Is it different in some of those fields? Is IR unique in some way?
I've wanted to believe that IR is unique, and I think it is unique in a couple of ways, but not that anything that is like life-changing or is changing in the way that people want to learn. I think IR is generally, I mean, broad strokes, so not always true. I'm sure there's plenty of other specialties that are as enthusiastic, culturally welcoming, as sharing with information as interventional radiologists, but those are some of the things that like I've always thought like IRs by and large are like adventurous physicians. And by that, I mean, if you talk to maybe a urologist and you're going to tell them, hey, today you're going to do a procedure you've never done before. And you know what you're going to do? You're going to just Google a lecture and then you're going to do it. They'd be like, oh, that's insane. They would never do that. And a lot of specialties would. But if you told an interventional radiologist, you're going to do a procedure today that you've never done, but you've got the know-how, you can do it. You have the technical skills to get it done. You just haven't done it. Most people would say game on, that's fine. And they have like the baseline skills that you need to do the procedure. You just don't have all the know-how, which has happened to me. Like I remember like for the same procedure I was talking about, for all the prep that I did, when it came time to like inserting this device, I had the package insert open. So this is a little piece of paper that tells you how to deploy the device. The patient's on their belly and I have that piece of paper open on their back. And I'm reading that as we're putting in the device, making sure that we're doing it correctly. I had it in my head, but I was like, well, the package insert's right here. Let's just keep this open.
Yeah, let's just see.
Yeah, it can't hurt.
No rep there or, whatever to help guide that.
No, there wasn't.
It's interesting because that's how this all started was, I mean, Aaron, I think in a moment like that saying, all right, look, I'm doing this procedure, but I'm using a device that I've not used before to do this procedure because that's what they had on the shelf at this care facility, at this hospital. And that's how everything started with this. I guess, do you encounter that? And like, I guess the related question is how big is the delta from one device to another on that same procedure?
Right. Sometimes the delta is huge, and I think like you would need a rep in the room to kind of walk you through it or familiarize yourself with the device before you went into it. It also depends on like, how big are the stakes here? Like for me, the stakes were fairly low. Like even if like, let's just say we put it in completely backwards, it's no sweat to just take it out and then get another device and put it back in. So like, I think you have to know the stakes, like what is like the point of no return? Like how bad of a pickle can you get yourself into and how easily can you get yourself out? But yeah, sometimes like the stakes are high, the devices are complicated, and you would not want to try something like that. But if the stakes are low and you kind of have a good grip on the situation, I think like it's fair game. But going back to the question, like, so is interventional radiology different in any way? I think we're adventurous. I think that we cover a breadth of material that makes it like difficult to be prepared for every single situation. Also, I think IR is like, there's no secret knowledge here. Everyone's like very willing, open, and trying to share cases. And so those are some of the things that I always thought made IR different. But slowly, I'm coming around to some of the other specialties can approach that.
Well, you guys are a little more MacGyver-ish than the other specialties from what I can tell.
I like to think so.
I mean, But back to the other question, I think what I'm hearing you say is on some procedures, the delta between devices is huge. And on some procedures, it's relatively tight. I mean, you can kind of swap one in for another and without that much thinking, but not always. Like there's somewhere it's really drastically different.
Yeah, absolutely. Like, I'm thinking about that, like in terms of needles that you put in a patient. Sometimes like you don't have like your primo number one needle, but you know that the next needle they give you, anything off the shelf, is going to be just as good as the one that you had before. You maybe just are unfamiliar with the nuances, but you take that same needle and hook up like microwave technology to it where it's going to heat up a tumor and kill something in someone's body. You really do need to know and be intimately familiar with that. And there's always going to be a first time you use a device. Like that's just a fact. And like I wish it was going to be in training, but that's just not the way it's going to shake out for most people. And so there's always going to be a first time you do a case. And sometimes you have to lean on your industry partners or your other colleagues to like borrow some of their experience. And what you do is you take chip shot cases where the stakes are low, where you think you have some wiggle room and you're by non-vital structures. And, that's how you get your learning curve up.
Do you have to go to training for each device you use, or some of you just wing and start using it?
It depends. I remember when I was like developing like a kyphoplasty or practice, or I wanted to at least be able to cover this procedure like my partners were covering it. I went to a course. They had like a cadaver lab where you learn to like deploy the device, got a feel for it, like, on a cadaver. So like you have a spine that used to belong to somebody. But like there are plenty of procedures where that's not really an option to you for one reason or another. And so you just do your best to prep beforehand. You have the rep come in with you in the room, and hopefully they give you some good advice. We do a whole podcast on what makes a good representative and what makes a bad rep. But
yeah. Oh, maybe the next topic.
You know what? Fritz has brought it up a couple of times.
Oh, really?
Mm-hmm.
I like that actually.
Yeah. There's plenty of good ones. There's plenty of bad ones.
Well, Beck, that's pretty much all I got. Thanks for taking some of your morning here to share. I guess anything else I didn't ask about?
No, I think we covered it.
All right, guys, thanks so much for listening. If you haven't already, be sure to follow and subscribe and rate us 5 stars. Also, share with a friend. If you do, who knows, there might be a BackTable hoodie in your future. If you have questions or comments, DM us. We're @_BackTableIND on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Anish Parikh,
and Ruchika Talwar.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and we'll see you next time.